welcome to another episode of Keeping London Healthy. My name is Dr. Mario Elia. Today we're going to be talking about advanced care planning, a really important discussion for seniors and their families to talk about what their goals are, what their wishes are for their health. So if you're a senior, please stick around for this episode. If you know somebody who knows a senior or you look after a senior, we'll be talking to Dr. Singh, who is an assistant professor of family medicine and palliative care at McMaster University. And we'll be right back after this message. All right, welcome back. I'm pleased to be joined today by Dr. Singh. He is a family physician and palliative care physician at McMaster University, where he is an assistant clinical professor. Dr. Singh, I'm excited to bring you on the show. When we first came up with the idea of this show, I was going through in my head, what are the topics that really are critical that we want to get across to the public, and where are the knowledge gaps? And the conversation we're going to have today was actually at the top of the list, and one of the top reasons why we actually started this show. So we're going to be talking about advanced care planning today. Dr. Singh, in your own words, what is advanced care planning?
So thanks for asking, Mario. So advanced care planning is a term that's come about in the last few years. Really, it's just a term for planning ahead for a time when a patient or family member is not able to make decisions for themselves. So sometime down the road, something's happened to them medically or otherwise, and they're just not able to make those decisions anymore, and they need someone to speak for them. So it really consists of a few things. The first thing would be determining who you want to speak for you if you're not able to speak for yourself down the road. So that would be a term called a substitute decision maker, also called an SDM, that we'll sometimes see kind of bandied around. And the second part of it is talking with that substitute decision maker about what your values would be, what your wishes would be in that instance down the road when you aren't able to make decisions for yourself. So advanced care planning really is more of a conversation and determining kind of who those important person or persons would be in your life. It's not so much of a written down document. It's not really the will that we're talking about. It's not a specific legal document. It's more of a conversation that's happening.
One of the things I hear from patients, when I bring this up, one of the things is they can't decide kind of who that person is. What do you suggest for those patients who, the first thing to decide on, who, and they're having challenges?
It's another good question. So it's really patient by patient. They have to come to that determination of who they think would be able to best speak for them should that instance arise down the road where they're not able to make decisions for themselves. So for some people, if they're married, let's say it may be their spouse, but maybe their spouse might not be the best person, in which case they may choose one of their children, for example, or a parent if one of the parents is alive and they wish to designate that person as their substitute decision maker. In Ontario, we do have something called the hierarchy of substitute decision makers. So that's something that takes effect, let's say, if someone does not choose someone to speak for them, then it's already entrenched in the law as to who that person would be. So typically, if no one is listed anywhere, then let's say the person comes to see us as the physician, who do we go to as the substitute decision maker? We would go down the list of the hierarchy. So we would start at the top being typically the spouse, let's say if they're married. And at any point in that hierarchy, that person, if they don't want to be the substitute decision maker, they're not forced to by the law. So they can say, no, I don't feel comfortable doing that. I wish someone else do it. So then it kind of goes down the ladder. So the next down on the ladder would be kind of all of the children combined. So if that person has not designated a specific child, then it would just be all of the children, and they all have to agree on whatever medically is being discussed. Next down from that would be both parents if they're both alive, or a single parent if one of them is not alive. Next down would be all of the patient's siblings. And again, similar to the children's situation, all of the siblings would have to agree to that medical decision. And then it kind of goes down the list to any other relative. And then if there's certainly no family members whatsoever, there's something called the public guardian and trustee, which is someone that the government basically appoints, and that person has to act in the patient's best interest and try to figure out what the best course of action is going forward.
I'm sure you've run into this a number of times where someone hasn't designated that substitute decision maker, whether they don't have family or whatever circumstances have come up, and it does fall to the public guardian and trustee. And I emphasize to patients really the importance of designated, because in the end you want someone
Yes.
making these decisions and helping, rather than it being some appointed person through the government doing these things for you. One question for you, Dr. Singh. We've had it in our practice a few times where someone has designated multiple children combined to be substitute decision maker, and I know there's some challenges around who in the family to which child to choose as a decision maker. Do you find that to be important to kind of choose one over a group, or what challenges does that raise if it is more than one person?
Yeah, it certainly makes it much easier for everyone involved if it is fewer people, ideally one person that is the person to be making decisions. The problem with making someone, let's say, multiple children to be joint decision makers, essentially, is that they both or all of them have to be in agreement with that treatment decision, with not just one treatment decision, but with each and every treatment decision that comes up along the way. So it really provides challenges to the physicians involved with treating that person, because they have to make sure that all of those family members are in agreement. And certainly it slows things down. It can cause family discord if there's not agreement. And certainly if we don't come to an agreement, we just kind of have to go with what we think might be in the patient's best interest, or err on the side of some decision that may not align with what the patient would have wanted. For example, if all of the children cannot decide on CPR versus no CPR, CPR being pulmonary resuscitation, where someone has to kind of push on the chest to try to restart the heart. If they cannot come to that decision, then typically we as the physician would have to err on the side of CPR and life prolongation, which the patient may not have wanted. So ideally, it would be best if someone decides on one person or fewer number of people to be that substitute decision maker. That would be ideal.
Now, the second component of this, in terms of that goals of care discussion, can you, and I know you run through these discussions very commonly with patients. Can you kind of give us a flavor of kind of what kind of things people need to be thinking about? What kind of things are you asking patients in these discussions, and what kind of things are brought up?
So with goals of care discussion, that differs from advanced care planning in the sense that goals of care is really more in the moment, deciding for a specific treatment right now, what should we do? So taking a look at, for example, if past values and wishes had been discussed already, that may help to shape goals of care, but it's not the entire thing that goes into a goals of care discussion. So really at that moment in time when we have to make a treatment decision, ideally if the patient's able to make those decisions, we would be chatting with them, but if not, then we would be chatting with their substitute decision maker or their power of attorney for personal care if that has been designated. And we kind of explain a little bit about what's been going on so far that led us up to this point where we're now having to make a decision, what the different options might be, perhaps what the different eventualities might be from each option. Perhaps if we had some data on kind of the chances of success for different things, we might offer that as an opinion. And sometimes patients or family members may ask us for our opinion on what we might do in that situation, or what we might suggest or want them to proceed with. And so if asked, I will provide that information as well. And then we kind of go from there and decide which treatment modality or which treatment decision we want to go with.
The advanced care planning discussion, then, what kind of things should patients be thinking about, and again, what kind of things are you asking them that helps to guide what their substitute decision maker needs to know?
They should probably be talking a little bit about what their values are in life and what their wishes would be, keeping in mind kind of what their overall health status would be at that moment in time, what they think their health trajectory might be in the future, and just having an open conversation, because it's not going to be possible for them to be discussing with their substitute decision maker about all different types of possibilities that may occur in the future or may not occur in the future. It's just not possible to go through all of those discussions. But what is possible is just to let that person know what you would value at certain points in time. Perhaps if, let's say, for example, you've really valued the taste of food and being able to swallow swallow. That may trump all else down the road. So for a treatment decision down the road, let's say if a treatment was being offered whereby that person would not be able to swallow anymore, for example, if they were not able to breathe for themselves and having a tube put down their throat and being sent to the ICU, perhaps that would not be in that person's interests if their overall wishes were to be able to continue to swallow no matter what. So that could kind of help guide the substitute decision maker or power of attorney at that moment in time when a treatment decision such as intubation versus no intubation is being offered.
The feeding example is a great one to kind of ask. Other ones that I will often ask them, if you're not able, if you're bed bound, what does that mean in terms of your quality of life, and
Yes.
whether or not you would want any, certain active treatments done at that point if you're not able to get up, if you're not able to speak for yourself, if you're not able to communicate. So yeah, and again, these are conversations over time too, right? Not necessarily like a static. You do something now, and you're bound by this decision indefinitely.
Yes.
But these are questions, and again, I would encourage again the children of those of seniors to be having these conversations with parents as well. Can you talk a little bit? You mentioned CPR. So this kind of, I guess, dovetails into a conversation about DNR orders. I know, anytime anyone's admitted to the hospital, when they're above a certain age, they're flashed some paperwork and asked, do you want to be a DNR or not? And people are often kind of confused and not really sure kind of what to make of that. So can you talk a little bit about kind of what that means and what patients need to know when making that decision?
That's a common question, as you mentioned, that patients may be asked if they're being admitted to the hospital. But sometimes we, in the community, as family docs, we will also ask this question at key points in time. For example, if we are bringing in a patient for their periodic health exam, or let's say they just got discharged from an extended hospital stay and they're now kind of more stabilized and we're bringing them in for their post-hospital visit with us in the office, then we'll kind of bring up that discussion. And so again, it kind of goes into advanced care planning, a little bit of goals of care, kind of thinking a bit about getting the patient to kind of understand and see what their state of health is at that moment in time. Maybe taking a look at the trajectory of how things have been going. For example, let's say if they've had numerous hospital visits in the past year or so, how have things been each time they've had their hospital visit? Each time, let's say they haven't bounced back quite to the same level. They're kind of going down slowly over time. So getting them to get a sense, first of all, of what their health state is and how it has been. Second part would be kind of taking a look forward and trying to predict how their health may go down the road. Some patients may have a condition where we can more reliably predict the decline in their condition, for example, cancer. Others, for example, cardiac disease. There may be times when we can't predict when that sudden cardiac event may happen, when their sudden heart attack would happen. So it's really hard for those patients to kind of plan ahead with respect to that. But given that in mind, we can kind of get patients to try to plan what their values would be if, let's say, their heart were to stop or if they were to stop breathing. And if we were successfully able to restart the heart or put a tube down to help them breathe, what would their quality of life would be? For some situations, what would the chance of success of CPR? For example, for cancer, that the chance of CPR for stage 4 cancer, let's say, if the cancer has spread to other places, might be closer to 0, in which case we might advise patients that attempts at CPR would not be a good idea. So kind of planting those seeds in patients' minds, working with them, trying to see what values and wishes they would have if that situation were to occur, that will kind of help them make those decisions about what matters most to them, and if they want a status of do not resuscitate, or also called allow natural death, or if they indeed do want an attempt at resuscitation, then we would not be providing them the DNR paperwork at that point.
The thing I often will emphasize to patients is that, do not resuscitate does not mean do not treat. Yes. So if someone does not want CPR done at any point, does not mean that we wouldn't treat pain, we wouldn't treat and they would still have the option of treating an infection if something reversible were to come up as well. And patients should know that they can ask their family physician for a form, a do not resuscitate form, to actually have in their home. I usually tell patients to put it on their fridge, because if something happens and paramedics are called, usually it's the first place they look. And if someone has designated that they do not want to be resuscitated, it's important that that's visible and present, because otherwise any emergency medical professionals will assume that someone wants to be resuscitated and they'll move forward with it. So I wanted to ask about resources, because I know people often ask me, what resources are there available for families and for seniors to kind of facilitate these goals of care discussion? Any resources that you point patients to?
Yeah, so probably the best resource would be one called Speak Up Ontario. It's run by actually an organization called Advanced Care Planning. That's kind of a branch of the government. So speakupontario.ca. Patients and family members can go on that website. They can learn about what substitute decision makers are, how to confirm a substitute decision maker. Let's say if they didn't want someone in that hierarchy and they wanted to name a specific person, then that would be designated what's called a power of attorney for personal care. So that website has some paperwork that you can fill out to designate your power of attorney for personal care. You don't have to go through a lawyer for that. You can just do that yourself if you wish. It gives some resources about talking with your family and with your substitute decision maker about what your wishes would be. And there's even a workbook on there to help you write down your wishes if you're that type of person that prefers kind of writing things down and having something written down as a resource for your substitute decision maker.
And I encourage patients and their families to check out that website, because it has fantastic workbooks and very easy to use resources on there. We're going to take a quick break, and after this message, we'll be back with Dr. Singh to talk a little bit about palliative care. And welcome back. Again, thanks to Dr. Stephen Singh for joining us today. And we're going to dovetail from the conversation we were having about advanced care planning into one of Dr. Singh's specialties, and that's palliative care. So, Dr. Singh, I know palliative care is misunderstood by some. When it's brought up, some patients kind of misunderstand what palliative care truly is. So if you can explain to us, kind of in your own words, what is palliative care? What do patients need to know?
So palliative care really is a philosophy of care focusing on symptom management for anyone with a life-limiting condition, regardless of what stage they are in that trajectory of their life-limiting condition. So a common misconception is that palliative care is just for end-of-life care, and that's not the case. It can be delivered anytime from the time of diagnosis of a life-limiting condition onwards, and really it can kind of coexist with more what's called disease-modifying therapies. So let's say, for example, for someone with cancer at the start of their diagnosis, maybe a lot of their care may be provided through the oncology team, the cancer doctors. So they may be seeing a chemotherapy doctor, they may be seeing a radiation oncology doctor, but they can also see a palliative care doctor even at the beginning of their disease trajectory. It doesn't mean that they're giving up on their treatment. It just means that we're there in the background, or perhaps in the foreground, helping out with any symptom management that may pop up at any point in time. And certainly as things progress closer to end of life, then palliative care does become more and more involved over time as well.
And I know you're, again, a family physician and palliative care physician. I know for a lot of patients out there, they may not know that their own family physician may actually do palliative care in the community. What do you find the relative uptake by family physicians who are interested in doing palliative care? I know certainly in your community, but do you find that most family physicians are kind of open to this kind of care for their patients?
Yes, I definitely do. I found that a lot of family physicians are very versed in palliative care, and indeed the majority of palliative care is provided across Canada by family physicians, especially family physicians with no extra training in palliative care necessarily, except for on-the-job training and perhaps extra courses or conferences that they've attended, but no specific dedicated teaching through the College of Family Physicians, that sort of thing. But yes, the majority of family physicians are involved in palliative care and are quite willing and happy to be providing symptom management care. Many of them do home visits. Many of them are willing to provide care up until the point of end of life itself. So not every single patient with a life-limiting condition needs to see a palliative care specialist like myself. Many of them can be provided excellent care, excellent high-quality palliative care through their family physician.
I'm glad to hear you explain it, palliative care in that way, because I know when we bring it up with patients, if not brought up, and if they don't understand what it truly is, just bringing it up, they could be discouraged and think, oh, I'm at the end of my illness. But like you said, in reality, someone with COPD with kind of persistent symptoms who is not close to the end of life, but has essentially a life-limiting illness that they'll eventually potentially die from the COPD, would be a candidate for palliative care and a palliative approach. Can you talk a little bit about kind of patients will often have a conversation about kind of those who are at the end of life, so palliative care, and we're actually at the end of life, whether it's weeks, months ago, and the conversation about kind of where that patients want to end up spending their last days, whether it be home or hospice or hospital. Can you talk a little bit about that, the decision that goes into that, and kind of what patients really should be weighing when it comes to kind of where they end up wanting to spend time?
A lot of it depends on what resources are available for that patient. So for example, if a patient is part of a large family and the family is willing and able to help out with that patient's care, then that makes it more likely for that patient to be able to stay in their own home environment. Let's say if a patient, on the other hand, has no family available, perhaps they're far away or perhaps they don't exist, and that patient lives on their own, let's say, it may be more difficult, if not almost impossible, for that patient to stay until the end of life in their own home. Reason being is that many of these patients with life-limiting conditions, at some point they will become more bed-bound. They won't have the energy to get out of bed anymore. They will need someone to help take care of them at that point, provide them medications. At some point they may not be able to swallow their medications, and they may need to have someone provide injections of medications for them for their symptom management needs. So it's really more difficult if there are fewer people available to help out with that, as opposed to more family members, let's say. And the reason I'm mentioning family members is that there are some resources available through the provincial government. Right now it's called Home and Community Care Support Services. Prior to that it was called the LIN. Prior to that it was called CCAC. The name keeps changing periodically, so it confuses everybody. But they are kind of the branch of the Ministry of Health that provides the resources in the home, like visiting nurses, visiting personal support workers or PSWs, occupational therapy, physiotherapy, and so forth. But even with maximal resources provided by the government, it's still not 24-hour care that can be provided at home. If someone truly wanted to stay home and was not able to have family provide that 24-hour care, they do have to pay out of pocket, unfortunately, for a private nurse or a private PSW to be able to stay in their own home environment. Let's say if they're not able to stay in their own home environment, there are other options for patients. So you mentioned something called a hospice. So hospice is like a standalone building. Essentially, it tries to emulate a home environment. It's not exactly the same as home, obviously, but it does try to emulate it as much as possible. Where I work in Brantford, we do have a hospice. We're actually pretty well served in Brantford because we have both a hospice that has 10 beds as well as something called a palliative care unit in the hospital that has 8 beds as well. And so those are some locations that patients can go, let's say, if they do have symptom management needs that they aren't able to be taken care of properly at home, or they just don't have the resources to stay at home any longer, and they are in their final few months or weeks of life, then they would become eligible to be admitted to the hospice or the palliative care unit, and then they would be provided 24-hour nursing care, provided essentially paid for by taxpayers, so no out-of-pocket expense for them. They would get their medications, nursing care, physician care, whatever they need, and provide hopefully a good end-of-life experience that way.
I encourage patients who know they have a life-limiting illness to speak to, if you're connected with a palliative care physician, talk to your physician. If you're connected with home and community care, speaking to your care coordinator about what options there are. Because I know here in London, we have St. Joe's Hospice, we have the palliative care unit at Parkwood Hospital, and the palliative care unit at LHSC. I really encourage patients who know that they may be going in the direction of potentially needing hospice to check it out. Uh, Obviously, during COVID, there were some issues with in-person tours, but virtual tours are an option. And I know hospice specifically, giving a plug there, that I've yet to have a patient who's gone to hospice who hasn't said to me shortly after, I probably should have been here a little bit sooner. It's a sigh of relief for families who've often been struggling at home with symptom management and caregiver burden, that once they're in that kind of setting, that there's a bit of a load off. So again, just a bit of bias there here in London for people to really consider hospice if they haven't already. So thank you so much, Dr. Singh, for joining us today and giving us some great insights about advanced care planning and palliative care.
Thank you for having me.
And thanks again to Dr. Singh for joining us and giving some great information about advanced care planning and palliative care. And until next time, stay healthy.